Thank you. Got to figure this out. We're going to talk about the GI tract and problems in EB. I can put it very simply. It has to go in and it has to come out. And if both ends work, life is good. If not, you've got a problem. The areas you're most likely to have problems is in the mouth. And Dr. Wright will talk about all the dental complications that can preclude a good intake. The esophagus is a target organ, particularly in recessive EB and causing strictures. Dr. Zieskan's talking about that tomorrow, so I'm getting everything else in between. And the only place that we really know for a fact that there are problems is in constipation and the colon. There's a lot of speculation about whether there are small bowel disease, like colitis, but it really has not been well studied. So, but a couple points I have to set the background because the GI tract is a somewhat innocent victim in this disorder. EB is a multi-system disease. It's a chronic inflammatory state, and the chronic inflammatory state per se affects the GI function. Chronic pain, as you've heard, unto itself creates a hyperalgesic state where normal bodily functions which would pass unnoticed become painful. And then overlay on that the chronic illness and the psychosocial issues. So virtually any part of the GI tract can be involved either primarily or secondarily. The secondary consequences are well known in the GI community, but not beyond it, and I want to talk about that for a minute. The liver, pancreas, and gallbladder are usually not affected unless it's totally unrelated to EB or it's related to a medication. The most severe complication that we worry about are the esophageal strictures, and as I said, that'll be covered tomorrow. Constipation, I find, is what frustrates parents the most. It's a common, frustrating issue. Now, as a result of all these above, you may have some malabsorption and malnutrition, and that sets off a cascade of events. And just to be complete, with junctional EB, there is congenital pyloric atresia reported, and there have been some duodenal and mucosal injuries. But I really want to concentrate right now on the secondary part. Malnutrition, and I'm sure Dr. Hubbard will speak extensively on this, but malnutrition per se is a disorder that affects every organ in the body. And it particularly affects the gastrointestinal tract, and that is often overlooked. And just because you see X in the GI tract does not mean it's a primary disorder. It may be secondary to profound malnutrition. And specific nutritional deficiencies, like zinc, have sequelae on the GI tract, which set up a vicious cycle. There's limited specific data in EB. Part of the problem is the tools I normally use are not something that we want to do in patients with EB, scopes, probes, etc., for fear of doing more damage. So it's hard to do good studies, but we've extrapolated from other conditions such as inflammatory bowel disease and other causes of malnutrition. Now, is this a common problem? Well, yes. And this is the best study I could find in the literature from Great Ormond Street. 253 children with EB, 130 had GI issues. In simplex, the most common were constipation and reflux. In the dystrophic forms, constipation, reflux, strictures, and the requirement for gastrostomies. There was a subset of patients who had diarrhea with evidence of colitis, and protein-losing enteropathy, which is loss of protein from an intestinal source, has been described in junctional EB, although they did not look at the rest of the GI tract and tell you specifically where it came from. Dr. Wright will cover all of these in his dental talk, I'm sure, but babies with EB have trouble eating from the very beginning. There'll be pharyngeal blistering, poor dentition, dental caries, ultimately microstomia, or small mouth develops, and this poor feeding and intake contributes to poor growth, which contributes to malnutrition, which contributes to other nutritional deficiencies, and around you go. The esophageal complications, again, will be covered tomorrow. But the main symptom is decreased oral intake, dysphagia, painful swallowing. It can start at any age. Strictures can be both proximal. One clue, if you have a physician, a radiologist that doesn't do a lot of EB work, if you have dysphagia and you get an upper GI, make sure they look high, because most of the strictures are up here. And a lot of times the radiologist starts looking here because they're looking for reflux type strictures. Reflux is difficult for us to quantitate in the usual manner because that involves putting a probe down, but it certainly appears to be a very common phenomenon, particularly in the dystrophics. And it may be a primary process. Remember, 40% of normal infants have some reflux, or it can be secondary to the ongoing scarring, stricture, and tension in the esophagus. It's more common in recessive EB. It can contribute to the scarring and the strictures, but it can be relatively asymptomatic. It can be difficult to diagnose unless the patient's old enough to tell you, I feel stuff coming from my stomach up into my throat and it burns. The best approach, we think, is aggressive treatment with proton pump inhibitors. That's the Nexium, Protonix, Prevacid, Prilosec, and their generic components. You may need a twice-a-day dose. The role of prokinetic agents such as erythromycin, metoclopramide, and for those from the United Kingdom, domperidone, is unclear whether it is of any benefit. Now, if you get on the internet, I always tell parents, the internet is my friend, the internet is my enemy. If you get on the internet, there's a lot of concern right now about long-term proton pump inhibitor therapy. All the data is adult data. That's not to say it doesn't apply to kids, we just don't know. The current concerns are with long-term proton pump inhibitor therapy, there's an increased incidence of community-acquired pneumonias, again, more in adults, Clostridium difficile infection, and I think EB kids are set up because of frequent antibiotics and other things that change their intestinal flora. The long-term concern is osteopenia, again demonstrated in the elderly, but in a group of patients who are already at risk for osteopenia, this may be a problem. And there have been reports of decreased magnesium stores. I don't know how to sort this out except to say we have to take a risk-benefit approach. If the reflux is significant, if it's contributing to the scarring, we must use the drug for comfort. Now, a caveat, this is recent data. If you're on PPI for anything, don't cold turkey it. If you do, you'll feel lousy. I think this is evil pharmacology that the drug companies came up with so we keep prescribing the drug. But in a recent study in normal adults who had nothing wrong with them, they had endoscopy and the stomach and esophagus were normal. They were put on 6 weeks of PPI and then stopped. They all developed dyspeptic or indigestion type symptoms. Most likely because you shut all the acid off, and if you cold turkey it, you rebound and you get rebound indigestion. So if you're going to stop a patient who's been on long-term proton pump inhibitor therapy more than 6-8 weeks, taper it twice a day, once a day, every other day, decrease the dose. Constipation. It's a common, if not universal, problem. I've been doing this for 40 years. I have no idea what constipation is. I only know it if you say you have it. I mean, that's about the best definition. The major reason in an EB is painful defecation secondary to anal blistering. Diet may certainly contribute, low in fiber and fluid. Opioid pain medications, as you've heard, are often a necessity, but they do aggravate the constipation. There can be colonic issues. You can develop an anal stricture, a secondary dilated megacolon, and very occasionally colonic rupture. This frequently becomes a behavioral issue. Constipation and the toddler is a behavior issue without EB. You superimpose EB upon it, it really is a chronic problem. You have to anticipate it, it's going to happen, and treat it aggressively. So first of all, prevent if I could do one thing in the universe, it would prevent anybody from having a painful bowel movement. because there are lots of psychological sequelae. Obviously, work on the diet, aggressive treatment. Now, Miralax was the first one out, and we use Miralax like you say Xerox or Kleenex. It's polyethylene glycol 350 is the chemical name. But anything works if the patient will take it. Miralax isn't any better than milk of magnesia or mineral oil or any of the other old compounds, but it's just that the kids will usually take the Miralax. And they may need a stimulant such as Senna. But prolonged therapy is necessary, and here's where the problem comes. I find parents either get tired of giving it, the child won't take it, or they're worried. So, the dose, first of all, is enough. As I always tell Dr. Lucky in clinic, you should give, kids having 2 caps a day and still having hard stools, give them another cap. The dose is enough. The dose has to be titrated to effect. At work, I tell people that a cap of Miralax is like eating 50 prunes. It has the same physiologic effect, which is to draw water into the intestine. Polyethylene glycol is an inert substance. The sorbitol in prunes is an inert substance that do the same thing. But the dose has to be titrated to effect. I get many questions about you doing this long term. I've had children on it 15, 20 years and have not been aware of any side effects. An overdose of Miralax results in diarrhea. And it'll go away as soon as you stop. So if you're concerned about long-term therapy, think about what the alternatives are. And that's the problem. Because taking a young child to the operating room to have to do a manual disimpaction from weeks of constipation is not a pleasant experience for anybody. The anesthesiologist, myself, the patient, the family, we should really avoid that. And just to close, are there small bowel and higher colonic issues? As I said, in junctional EB, there have been some reports of low serum albumin and elevated fecal alpha-1 antitrypsin, which is the gastroenterologist's marker for protein-losing enteropathy. 5% of EB patients have chronic diarrhea. The most common reasons are laxative overdose and anal stricture, but there may be some small bowel disease or colitis. There have been several reports of colitis in the literature, but to a gastroenterologist, the pathology is nonspecific and doesn't tell us anything. If there's a new kid on the block, though, in GI, if you're concerned that there's some intestinal inflammation, fecal calprotectin is a wonderful test to sort out yes, no, is there inflammation. It's not specific. It won't tell you what it does, but it very nicely, at a level of 50, tells you whether there is inflammation in the gastrointestinal tract. And this is what in gastroenterology we use to decide whether a child needs further evaluation, colonoscopy, etc. I know of no data in the EB population using this, but it's a non-invasive way to begin to look at it. And I just want to close with what I started. Malnutrition, which I'm sure Dr. Hubbard will talk about in great detail, affects the gut and causes more malnutrition. Malnutrition per se is a multi-system disease. It affects multiple organs, and the combination of chronic inflammation and malnutrition is very deleterious to the function of the normal gut. And here's just a list of changes that have been described in the normal intestine in patients with malnutrition. You don't make as much acid, bacteria grow where they're not supposed to grow, the mucosa gets flattened and doesn't work, your bile changes, you have fat malabsorption, you absorb things that you shouldn't absorb, which cause other reactions in the body. The microbiome, or that's the intestinal flora, changes. You get a fatty liver, you can't make albumin, your pancreas doesn't work, and you get specific nutrient deficiencies. And all these are secondary to simple malnutrition before you superimpose anything else on it. So, with that,